Welcome to Sierra Health Foundation and the Center for today's forum, a policy conversation on family caregiving for older adults. I'm Joan Twiss, Senior Program Officer. First, we are pleased to present this program in partnership with several organizations, many of whom have representatives with us. They may not all have arrived, but we're going to go ahead and at least mention them by name, and I would like to have you just raise your hand or stand in place, whatever you're most comfortable with, so people know who you are as far as our event partners. So AARP California, Nina Weiler-Harwell, Associate State Director. And from the Alzheimer's Association, we have Susan DeMorris, California Director of Governmental Affairs. We have Sergio Calderon, who is the Regional Director of Alzheimer's LA, serving the Inland Empire, and Nicole Gutierrez, Legislative Assistant. From the Archstone Foundation, we have Mary Ellen Coleman, Director of Administration. From the Association of California Caregiver Resource Centers, we have Michelle Nevins from Del Oro Caregiver Resource Center. We have Kathleen Kelly, who is our first speaker, who is the Executive Director of the Bay Area Caregiver Resource Center and also the Executive Director on the National Alliance for Caregiving. Erin Levy, who is a partner with Capital Partners and affiliated with the Association of Caregiver Centers. The California Commission on Aging, Carol Sewell. MetaFund, Janet Spears, CEO. Placer Community Foundation, Eileen Speaker, Grants Manager. Great, welcome. The Youth Movement Against Alzheimer's, Nihal Satyadev, co-founder and CEO, and also one of our speakers today. We also are very pleased that we have as event partners Grantmakers in Aging, the California Endowment, and the Rosalind and Arthur Gilbert Foundation. So I'd like to recognize just a few additional folks who are with us this afternoon. From the Gordon and Betty Moore Foundation, Ms. Susan Song. Program Officer, Ms. Christina Ta, Program Associate. From the SCAN Foundation, Ms. Sarah Steenhausen, Senior Policy Advisor. From Speaker Rendon's office in the California State Assembly, Gail Gronert, a Special Assistant to the Speaker. Welcome. From the Senate Human Services Committee, Taryn Smith, Chief Consultant. And Jessica Zaragoza, Legislative Aide in the California Senate. So this is an incredible turnout. We are so happy to have each and every one of you here. It's now my honor to introduce Kai-Ying Hang, Vice President of Programs and Partnerships for the Sierra Health Foundation and the Center.
Thank you so much, Joan. And I want to do a quick shout out to Joan, whose thinking and whose innovation has brought all of us together. So thank you, Joan. On behalf of Chet Hewitt, our President and CEO at the Center and the Sierra Health Foundation, I want to welcome all of you to the Foundation and to the Center for those of you who are here for the first time. We're delighted to have you here. We're so pleased that you are joining us today for this third conversation on older adults, this one on policy conversation, consideration for family caregiving for older adults. This is a significant issue for many of us personally, and we had a chance to talk with a couple of our speakers during the lunch, and so we know how intimately, personally, some of this issue that we're talking about is for all of us. And as we know, the ramification extends to the society as a whole. To that end, we applaud Archstone Foundation and AARP California, who provided grants to the University of Southern California School of Gerontology to convene thought leaders and practitioners to provide recommendations to the state legislature for policies to support family caregivers. At the Foundation, we are pursuing this conversation in partnership with the many organizations that Joan mentioned because of our deep and shared commitment to addressing the social determinants of health. We know that the racial and ethnic disparities experienced from early ages forward impact health, safety, and overall well-being as older adults. Furthermore, the direction is consistent with our work here at the Foundation and the Center, which is policy and systems oriented. We look forward to a robust conversation this afternoon and the opportunity to connect with each other who share similar policy goals regarding family caregiving. So with that, I'm going to turn it back over to Joan.
Thanks so much, Kaying. Well, the case for policies to support caregiving is compelling. Reviewing the literature from both the organizations represented on the panel, AARP, the report from the California Task Force on Family Giving, and the website for the Family Caregivers Alliance and the National Center on Caregiving, I'd like to just start us off sharing the following. In California, between 2015 and 2050, the 85-plus population will more than triple, while the caregiver support ratio, 45 to 64, to the 80-plus, is projected to shrink, 7.4 to 3.0. In California, during this same 35-year window, from 2015 to 2050, Hispanics as a percentage of the population in this 65-plus age group will experience the most growth by a huge margin in comparison to other racial ethnic groups. It will double from 19% to 37%. And this is significant for a number of reasons, but for today's discussion, caregiving burden falls disproportionately on populations of color. Just as one example, Hispanics and African Americans in particular will start caregiving earlier. It will most likely involve multiple areas of support, and because they are likely to have less assets, have a disproportionate impact on their health and financial status. So it only makes sense that we look at policy-based ways to address these caregiving impacts. To do that, we have a very distinguished panel with us today to explore these issues in greater depth. Among the many attributes, they are experts in family caregiving, Alzheimer's disease, state and government legislation. In the audience today are leaders from a variety of these and other fields from throughout California. We very much appreciate each and every one of you taking time out of your very busy schedules to be here. You should have a program agenda that looks like this, which provides us with the sequence of speakers. They are going to each speak in order and take only clarifying questions initially. Then we will have a networking break, 15-minute max. We'll start giving you the, sign to come back in just before that. And then we'll have a moderator dialogue with the panelists themselves and then with the audience at large. We will ask that you wait till the microphone gets to you to ask your question because we are recording today and we are driving people to our website as much as we possibly can, not only for this program, but for the two previous programs that we've had. So, our speakers include national and state level experts who bring a wealth of real-world experience to this discussion. Ms. Kathleen Kelly, who is Executive Director of the National Caregiver Alliance, as well as the Executive Director of the Bay Area Caregiver Resource Center, has decades of experience and leadership in the field of caregiving. She has led state and national panels, authored publications, and advocated for systems reform and legislation. Now, many of you in the room, because I've already met with you and talked to you about this forum, know that I do a lot of due diligence to get my speakers. Never have I had all roads point to one speaker that we had to have here today, and that was Kathy Kelly. I say that without a bit of exaggeration, and I'm so happy she was able to be with us. I'm going to introduce the other two and then turn it over to them. Mr. Nihal Satyadev, co-founder and CEO of the Youth Movement Against Alzheimer's, known as YMAA. In 3 short years, YMAA has become the nation's widest-reaching nonprofit to provide youth a multitude of opportunities to get involved in addressing this disease. Like a true millennial, he has many interests and pursuits, including socialpreneurship, biomedical research, advocacy, and I learned at lunch, mountain climbing. He recently spearheaded the AmeriCorps for Caregiving, a respite program for caregivers. We will be seeing more of Nihal. And remember, when he's getting his awards, you saw him here. Ms. Sandra Perez, former patient advocate for the state of California, is our moderator. She was at the forefront of the state's initial healthcare reform proposals and consulted on aging policies. She served as a consultant and staff to the leadership of the state legislature. And she has directed a number of UC and CSU leadership programs. So without further ado, let's get started. Please help me welcome Ms. Kathy Kelly to the podium.
I think I was chatting during the time for the slides to be on for the technology. Where is the, I don't have a, oh, this is where I shouldn't have been chatting so much. I was catching up with everybody, the keyboard. Oh, that's not it. Okay, can somebody please help? Well, oh, yes, that would help. This one. Okay, and how do I get the menu off? Press the menu button. Actually, this is sort of a funny thing because for those of you who know me, know that I have been working on a technology project as the lead on a technology development project for the past 4 years. And so this is kind of embarrassing. Anyway, I'm so glad to see all of you. I know a lot of you. I feel like this is like old home week, that we should probably just group the tables around and have a pitcher of beer and some pizza, and that would be great. And I do appreciate you being here. I feel like you've all heard my spiel before, but, probably not everybody in the room. I've been, around. This such a nice introduction, is to say that when you hang around long enough, like I have, and beat the drum long enough on a certain topic, people start to think, oh, she must really know something about that topic. But suffice to say that I have worked decades in the field of caregiving and really got started actually when Jerry Brown, in his first iteration of governor, signed a bill that made California the first state in the country to recognize that there was such a thing as family caregivers and they needed support and services. And that was in 1979. The bill got started, the implementation got started in 1980. And so that's by way of dating myself, because I was a teenager when I took this job, that's when I really got started in this field. So you can say, yeah, I've been around for a while. So I'm going to talk about sort of the broad brushes of some of the policies and also hone in on the policy recommendations that have just come forward from the California Task Force, because, we spent a lot of time honing these things together in sort of tortured conversations, and I think it's a really sound and excellent document to look at. So just by way of context, these are, statistics that you probably have heard. There's 4.5 million caregivers for adults age 18 and older. Most of them are women, 60% are women. On average, it's kind of a baby boomer world, a little bit Gen Xer world. 1 in 4, as Nihal's going to talk about, are millennials. So we start to, I'm going to tell you, because I've been working in the tech world, when you're thinking about this kind of thing, you have to think it's not just that 49-year-old statistic. It's multi-generational, and will become even more so in the future. Most of our caregivers are employed, so they have double duty. They're working and they're also carrying a full or part-time job when they leave their workplace. And their average time is 4 years, some shorter, some longer. Some people we've worked with in our agency, it's been much longer. And the economic value is $57 billion, if you looked at all the things that caregivers do. So I'm going to step back for just a moment and say that we have I work for an interesting organization, which is why one could never really get bored unless you have a lack of imagination. You could never get bored working where I am. And that's because we look at both the policy implications and we also have a foot in direct services. So when I talk about direct services, I'm talking about real families that we see every day, and the data comes from those families. And I'll talk about that in just a minute. So what do caregivers do? They do everything. We never use, unless it slips, the term informal. There is nothing informal about caregiving. There's nothing casual about caregiving. Caregiving is a job that has many different tasks. Not everybody does all of these tasks, and these are just some of them that I took from a list that Jennifer Wolf at Johns Hopkins put together. We just, we tend to think, well, families just go over and they help mom shop. But really, we know in complex care, half of the caregivers are doing very complex medical tasks without any training. So these are some of the components that families do. There's nothing informal about what families do. Families do just about everything. And mostly, I talk about families as a plural, mostly there's one person who's doing most of those tasks. So I'm going to talk about the families that we see in the San Francisco Bay Area, a slightly different profile. All data has its contortions. Our contortion is that we have more money in Title IIIe programs, so things tend to be a little bit more skewed because of the focus on lower socioeconomic demographics and targeting that population. We see mostly women, 75%. Now, there may be 40% of men who's caring out there, but for help-seeking individuals, it's women. The average age is 58, a little bit older. 57, same employment rate. Very diverse population. You can see, you have Asian, Pacific Islanders, Caucasian, Latino, African American. So very, very diverse population in the Bay Area. The majority of the primary caregiver, and 82% are getting no or less help than they need. When I say there's one person, there's almost always just one person, tag you're it, in the family. 42% have been caring 2 years or less, but many of them have multiple years of caregiving. So that's a proxy in some ways by talking about the complexity of issues that families are dealing with. The majority for us have a cognitive impairment, majority have dementia. Caregivers report a lot of stress, 92%, more than they can handle. Anxiety is high, depression about 40%. And social isolation, we use the Lubin social isolation scale. This is a little stunning. 67% indicate they're socially isolated. And in the API breakout that we did recently, it's 71%. So we need to think about this as being a health issue as well. It's like equivalent to, what did I see? At least 7 cigarettes a day or whatever it was if you were socially isolated. So here's all the challenges that caregivers face, the health impacts, back problems, poor immune functioning, increased mortality, possible increased mortality, and then the financial impacts. We don't really talk enough about the financial impacts. We talk about stress and depression, but this is actually a pretty expensive job. You're doing a job and yet you're paying out of pocket, on average, about $7,000 a year on supplies and other kinds of things. That's kind of the yearly average. And there's also negative impacts on employment. If you cut back your job or you leave employment status, there are no Social Security accrual benefits. Do you know how many calls I've had from family members that said, a family caregiver who is now, in her mid-60s and said, I'm 3/4 short on Social Security. It's a pretty common call. It's a usual and customary. So, reduce savings opportunities, increase risk of poverty, to be sure. So we don't talk enough about the financial issues. Sometimes in families, you can talk more about sex than you can about money, for sure, but we don't really, this is a taboo topic. We don't really talk about the financial impact and what we can do about it, because most of our families are not on Medicaid. They're really a middle income or lower middle income, and the choices and options for them are pretty minimal. So I was thinking we should have a blue sky statement. We do at our organization, pretty much mimics what we have. If we were to say, what would we like to see in the state of California, or for that matter, any state in the country? We think all families deserve a range of high-quality services and supports and policies that promote their physical, emotional, and financial well-being at home and also in the workplace. This is what we're striving for in all of these policies. So this is sort of the show me the money slide here for the state of California. When we talk about who funds policy, so we're going to talk about who funds policy, what policies have been in place, and what are the policy recommendations as I move forward. We have two direct state-funded components of services for explicit supports for families. So what do I mean about that? These two programs have the family caregiver as the client. The eligibility is the family caregiver. And when we talk about explicit, I always get, well, a daycare program, promotes respite, gives respite to the family. But the eligibility is based on the person who attends the program. Respite is a benefit for the family caregiver, but a family caregiver can't come in and say, I need respite. Well, if you could pay for it, that's fine. But your need for respite is not the eligibility criteria for using that program. It's a benefit. It's an implied benefit of the program. So when we talk about services, we're really talking about two things. One is, what are the services that are directed towards the family themselves, or towards the caregiver? And what are the services that support because the caregiver derives benefit from them, but it's really based on the eligibility of the person who needs assistance. So these are the two programs. The National Family Caregiver Program, the Title E3 program, which was, crafted in part by state experience, California being one of the states when this was put together. And it's run through the Administration for Community Living, Administration on Aging, comes down to the state units on aging. It goes to the 33 area agencies on aging, and then they contract or not for services, a package of services that you can see up there. The criteria is kind of restrictive in the sense that it's restricted to adults over the individual needing assistance needs to be over 60, except for those who have dementia. Any age qualifies. The caregiver could be of any age. So it's a little bit more restrictive in that criteria. In the network of CRCs, this is the replication piece of legislation after the pilot project in 1980, is a little less restrictive. It's adult onset of cognitive impairment from 18 up. And the caregiver can be of any age. Caregivers always have to be 18 and older. So it's much more global in terms of ages. So in our work with the CRCs, we see 40-year-old stroke patients. Somebody who's 50 has Parkinson's. Somebody who has a lot of other kinds of disabilities from other physical ailments. So we see a little bit different profile in the CRCs. We see younger, by and large. The net total of these two programs is about $28 million. If I'm doing my math correctly, I'm sure there's people who probably know the exact appropriations, but it's about $28 million. So what we're really saying is we spend about $6 per caregiver in the state of California. This has gone up. It used to be what I would term, in a few years past, a latte at Starbucks, but it's gone up to $6, so maybe you can have a pastry with your latte. So it's equivalent to $6. So we don't really spend a lot, but we get a lot in return. We get $57 billion worth of services for the investment that we're making right now. So before I go on, I'd like to, no, I'll go to the next one. So what kinds of policies directly support family caregivers in the state? We actually have been a state of firsts for quite some time. We passed the legislation, which I alluded to, caregiver resource. We were the first state to actually recognize that there were families. That's great. We were the first in the country to pass paid family leave. That covered elder care. There's been some leave policies in other states, but they've really been for leaves for adoption and for family bonding, that kind of care of a child kind of thing. So we pay family leave. We've also been a champion of consumer-directed choice in home and community-based services, thanks to the proactive disability movement in the state. We've also passed other supportive policies. We have the CARE Act, which identifies hospitals must identify a family caregiver at the point of entry and also at the point of discharge, to have family members included in discharge planning and be taught any special instructions about the healthcare needs of the patient being discharged. We did actually have a tax credit, small, I think it was around 500, 750, something like that. It sunsetted. It was in the middle of the recession. No one wanted to put any more burden on the state budget, so it sunsetted. And then we've made a lot of different refinements to the paid family leave program. Paid family leave has a pretty strong voice. There's a Work and Family Coalition. I'll just make a commercial for them. They just issued a report, a wonderful report on paid family leave and workplace policies that just was issued like in the past day or two. Yeah, yesterday. I mean, this is really hot off the press, but it's really great. So there's an active work and family. I want to say when this paid family leave was enacted, which was in 2002, and looking at it a few years later, we had about, it was less than 20%. I think it was somewhere around 12 to 14, 15% roughly when it was passed. Now it's under 10%. We don't have a lot of utilization of this program now. It hasn't changed. Still working caregivers. There's some recommendations to do some changes within the program, make it easier for people to use. What I'm saying is that it's a policy there that it's not actually being utilized to its full extent. I'd like to make a few observations on policy in this direction, because the next set of slides I'm going to talk about the recommendations that came out of the task force. But I'd first like to make some more global global comments, coming from my perspective of being in the field for a while. The first is there is no one silver bullet policy that's going to solve the problem of caregiving. It's really a package deal. It's a whole bunch of things that look at the very big, complex issue of family caregivers. It might be on the financial side, it might be on the care side, it might be on, advanced directives, you name it. It's a lot of different things. So there's just not one policy. The second is, in the past 8 years, of course, we've had the Brown administration. And I love Jerry Brown. I love his stand on the environment. I like the fact that he guided the ship and righted the ship during the time that we had, during the recession. We sort of forget about that now, but, we were pretty much a sinking ship during that period. But I would say that actually the area of caregiving, not exactly his interest, even though he actually signed the original piece of legislation. But there have been some other ways in which the Brown administration has been working in a direction that's overall policy, mostly, I would say positive. Some advocates might have a little bit different opinion, but with managed long-term care services supports, the dual eligible program expansion of Medi-Cal in general to cover more Californians with basic health care. So a lot of things have been really positive, but on the side of what we're talking about, there hasn't been a lot of uptake. It's just not necessarily his thing. And I'm not saying that in a negative way. I'm just saying that for a lot of the policies that have been passed, they may have been tweaks around the edges for looking at paid family leave policy, but there haven't been any money involved. There hasn't been money involved. It's been a little bit of tweaking here and there, but mostly we're kind of all sort of idling at this point in terms of our advocacy. So he's been great in these areas. We know that the recession, we got through the recession. It's sort of in the rear view mirror at this point. But I have to say there are a lot of programs that got cut during the recession that I just want to give a shout out to. I mean, one of them was us with the CRC system, took about 70% of a hit. We got a little bit restored, but we got really quite decimated, slated for elimination. But I also want to mention that the adult day healthcare programs were slated for elimination, and it took a Herculean effort to keep the adult healthcare programs intact in California. Herculean effort on the part of CADS and all the different advocate groups that came together. But there was a third of the ADR, adult day healthcare programs that went under during this time period. And a few of them come back, but we've lost capacity. That's the message. We've lost capacity in many of these services for the most understood of reasons because of the recession. But I just want to mention, we're not at the starting point that we were, say, 12 to 15 years ago. We're not even at that starting point. We're sort of behind that starting point in a way. We have less capacity for community-based services outside of IHSS than we've had in the past. So caregivers are increasingly being recognized. In some ways, it's kind of amusing. I would say we're overnight success, but obviously that's not true. It's been decades. But more people are talking about caregivers. But the problem is that we haven't talked about them in operational ways. What are we actually going to do? It's like, we know caregivers do those really important tasks, and they should be supported, but we never say what that means. We never quantify it or operationalize it. Is that a word? At any rate, operationalize it. So things like questions around uniform assessment. Why aren't we assessing caregivers in some of our other programs across programs? We don't know. We haven't we've hit pause for a long time. We've not made any movement forward on assessing. Even though in IHSS, for example, there's other states, there's about 7 to 9 other states that assess caregivers, not California. California is the tail wagging the dog, by the way, in the state system. We have 500 IHSS, give or take, whatever time period you're talking about. And most of those workers are family members, but we don't assess them. We know they're there, we don't assess them. We don't train them, we don't assess them. And that's not the way it is in other states. So we've had because of some of our research we've done, we've had some opportunity to really look at that. The other thing I want to say, and this is sort of a little stunning to me, you know how sometimes you think like you pretty much know all the statistics? I was telling Mary Ellen this over lunch, that I had a colleague state in a paper I was reading recently that less than 10% of community-dwelling older adults get services through Medicaid. 10%. Does that sound odd to you? Less than 10% of community-dwelling older adults, those over 65, get services or use Medicaid services. I'm only saying that because, my observation, and I've sort of, I dip my toe in and out of state politics and policies. I work on a lot of different committees and things. But I was a little taken aback, and I said, that can't be true. So I went and I looked at the Department of Healthcare Services to see what percentage of people over the age of 65 are on Medi-Cal, 9%. And they cost the Medicaid system, the Medi-Cal system, 35% of spend is on that 9%. 35% for those who are disabled and blind, and the other 30% for low income, getting basic kind of healthcare services. Now, why is that shocking? Because 90% of the conversation that I hear in policy is all about Medi-Cal. All about Medi-Cal. That's the dominant conversation. And so I'm always kind of a little bit struck. I mean, really, this has been bothering me. Like, I would say, oh, it's dual eligibles 24/7. That's in my head. That's you're getting the bubble outside of my head when I would go to all of these meetings. But it's really true. So 90% of the older adult population is not getting in-home support services or home community-based services through Medi-Cal. So let that sink in for a moment. There is an odd conversation that we have with many families, going back to the anecdotal and personal, that there's a doctrine of fairness. They wonder, listen, I've lived in California all my life, I've paid my taxes, why is there nothing for me? Or why do I have to become impoverished in order for me to get help? Think about that for a moment. There is a fairness doctrine that people bring up to us, and I think that we need to recognize that. At any rate, I'm full of these little statistics these days, but I think that's something that we have to recognize in these policy discussions because, right or wrong, or for whatever reason, we tend to talk about, when you talk about long-term care policy, even with policymakers, they'll devolve down to what they know. And what they know is Medi-Cal. So we have to raise the conversation, but we also have to raise it again around that financial issue called above the impoverishment level. We have to raise it for middle-income families. So the creation, sorry, there's all these acronyms, the California Task Force on Family Caregiving, ACR, I had to write this down because I never remember, Assembly Concurrent Resolution that was passed a couple of years ago that created the task force that I'm going to talk about right now. This was done because through this resolution, fortunately, there's no money attached to it in terms of the resolution, but AARP and Archstone Foundation funded the infrastructure that was needed to really formulate the task force. And so we had a lot of experts on the panel, but I also just want to, before I move on, just want to do a shout out. There's a lot of people who are activated in these discussions of policy, and so I just want to recognize that there is a California collaborative for long-term services and supports in California. There's 37 statewide organizations in there. It's been around since 2011. It's great because it's the only place where people can get together. California is a big state, and to have a communication channel with organizations is really important, and the collaborative does that. There's a lot of funders in the room here that are interested in advocacy and policy work, policies that will favor family caregivers. Thank you very much. I know Mary Ellen's here from Archstone, but also SCAN and other groups that have really been in the forefront of funding works, papers, and other kinds of studies that move forward, as well as advocacy work like the State Plan for Aging and so on. There's small work groups that have been going on across the state on various issues. A couple of years ago, we looked at insurance issues and social insurance for long-term care. AARP has been in the forefront. SEIU, obviously, in the unions, service organizations, disability groups, associations like the Alzheimer Association and others. And professional organizations like CAD. So there's a lot of people that are in this conversation, and I would say, with hands down, all of these groups across the board support family caregivers. Oh, I'm sorry, I go on. Okay, so the recommendation is around the financial, this is recommendations from the task force. Support the financial well-being of family caregivers. So we're talking about introduction of tax credits again. Stipends that defray the cost of programs. There's a small program, by the way, going on that's doing just that in San Francisco out of Dignity funds, city and county funds right now. Build on medical, the paid family leave, but really to actually promote it to be used more and to make it more user-friendly for people. To modernize and standardize the caregiver assessments. We really have very little data on families, across the state. And to support with the assessment, the individualization of services, tailored services to families. So to implement a standard assessment tool, this is the holy grail that we've all been working for many, many years. Increased funding for caregiver assessments. They said, well, we'd like to do it, but we really don't get paid to do it. And to be able to collect that kind of data across service delivery systems so we know what's going on with family caregivers. And then remove barriers to inhibit safe return, which I think is being done in some communities. We want to equip family caregivers with easily accessible information and education and do it in a culturally appropriate way. You know, we do a lot of in-person programs, and I call that the retail aspect of what we do, but we really need to wholesale this information and make it available to everybody. That's our charge with looking at technology use, but it's not the only way you do it. But the fact of the matter is that we have a lot of diversity in our state, which we pay lip service to. We have very little information in those languages when it all is said and done. And then increase funding to the CRCs as well. The recommendation to access to affordable caregiver services and supports, including respite care for people to take a break. Even with the money that's in these two programs, the respite care is rather small. The average respite grant on an annual basis, maybe around $500, maybe $700. Think about that for a moment. It's not very much. It's really, really small. And I know Nihal's going to talk about expanding respite in just a minute. Integrate family caregivers into hospital processes. I would say actually the healthcare system in general. 50% of older adults go to visit their doctor with a family member in tow, but they very rarely are included in the interview or in the discussion about care, even if the patient indicates they want them to be involved. So, and then we're talking again about people who are doing very complex tasks. We don't have nurse delegation in this state. We delegate 2 out of 16 usual and typical nursing tasks, and we need to delegate more. It's a matter of for people to be able to hire aides to come in and do some of those tasks, medication being one of them. Just giving medication is really a hassle. And then make sure that we've standardized the hospital discharge process as well. We are doing a little bit of work, I say we, as if I'm so intimately involved, but the group that's looking at the implementation of the CARE Act with ARP. I'm sort of peripherally involved in looking at some of the data. But we need to, when you think about implementing the CARE Act across 5,000 hospitals in the United States, it's a pretty big task. So we need to make sure that we have a hospital process and discharge that is amenable for families. And we need to start to utilize telehealth for caregivers and for care recipients to make their lives easier. So to promote the use of telehealth for routine kinds of visits and questions. We, again, wanted to increase the California's Caregiver Resource Centers to expand the services they do. Let's leave it at that. The last recommendation is to create a statewide advisory, really more at the level of HHS within the cabinet, so something that is a body of opinion that can seek to provide advice on these various kinds of policy issues. That's the last recommendation. If I have no minutes, okay. If we're talking about working through some of these policy issues, it would be good to be able to raise them in a standard way and have a process to seek informed opinion about how we might move forward on some of the issues that I've been just talking about. And finally, I'm going to leave you with this. I don't know if anyone reads Roz Chaz. She's a New Yorker cartoonist, but she wrote a graphic memoir about caring for her family. It touched my heart, mostly because she has kind of New York Jewish humor, and that's my husband. And so by proxy, I've developed this same sort of humor. It's really a wonderful book if you haven't read it. But actually the book is titled, Can't We Talk About Something More Pleasant? Which of course is really what you do with families. But the point being is that we really need to accelerate this public dialogue and accelerate the action about caregiving. We've just told about the changes, demographic changes that are coming our way. We really don't have a lot of time to waste because we really are going to fall off the cliff in terms of family members available, the ratio of family members available to take care of the baby boomers, meaning me. I have 2 daughters. And I don't necessarily expect them to, mate all of my needs, but I'm thinking, I did send you to college, so I'm hoping that comes back to me in that way. But the point is that we are going to be falling off the cliff. The kind of support that we're talking about right now is not going to be as readily available through unpaid means as we have it now. So this is as good as it gets. And we know that it's going to not be as good in the future. So I'll leave it and I'll have Nicole come up. Are you going to do an introduction?
All right, hi everyone. I guess this is Kathy's last slide. And additional information. And there we go. So hi, good afternoon. My name is Nihal. I'm here to talk to you a little bit today about kind of how I got involved as perhaps one of the younger people in this room, and also a little bit about how we as the younger generation can really be making an impact in this space. So this is my grandma. I call her Amama, but her name's Sarah Money. No birth certificate, was born in rural India, and she was diagnosed about 10 years ago. And so really seeing what the stress that put on my grandfather, who's been a lifelong police officer, has been in very high stress situations, and seeing that being something that was difficult for him. And then my parents in terms of going back and forth between here and India, finding the right care services there, which are a little bit more affordable. But just seeing that really pushed me to start learning more about the field. I got involved in research. I worked in a number of neurodegeneration labs. I'm still working on a clinical project today. But along the way, I started doing policy work as an intern for Alzheimer's Association, and that's where I started looking at the numbers beyond, the research. And these are national figures. I know we're kind of in a California space here, but the fact that there's this many people with the disease, and the fact that this many people with Alzheimer's are creating so many more people clinically diagnosed with depression was really shocking to me in seeing this both as a memory loss disorder, but also a mental health issue. And then more impactfully was the fact that how quickly these rates are growing. And I know I'm really preaching to the choir here, but when I go back and tell my friends in college or young adults, they are not the choir. People don't understand their healthcare access is completely at risk here, and not really affecting them necessarily when they retire, affecting them potentially in their early 20s or late 20s, early 30s. So that's the message we've really been spreading in creating the Youth Movement Against Alzheimer's. We started off highly focused on advocacy, spreading the message that this doesn't need to be in your family in order for you to get invested. What's really exciting for me is that close to 50% of our members actually have no familial ties to this disease. And so we're really looking at this as a global challenge. Right up there with climate change. We look at these major trends and these big organizations. I know just a few weeks ago, we had the Global Climate Action Summit, and why don't we have that for Alzheimer's? Like, why is this not on the same space? Because this is going to have the same sort of ramifications in terms of how it's going to affect people across the board. So that's really the kind of message we're trying to push here. So we have young leaders. These are college and high school students, who are rising up to the challenge across a number of majors, primarily pre-med, and pre-health, but, we have a public relations major, and a few other, non-traditional health majors who are looking at this quite differently. So this is kind of a little bit about how we compare to other organizations, but the point here is really not so much that we're doing a much better job than them. It's just more so about the fact that when young people put this issue in front of other young people, we are able to radically change the conversation. And I think that's really what's been the difference, is not that we are doing something completely different from traditional Alzheimer's organizations or elder or aging organizations. It's just the fact that until maybe 3-4 months ago, everyone on our team was under 23. And so that's kind of the difference. So along with when we started our advocacy efforts, we also put together a few other initiatives, and our efforts on care is really what I want to focus on today. In fall of 2015 was when we started this program called Timeout at UCLA. And I have a video which explains it a little bit more, but it's a simple partnership between, after a training of undergraduate students, partnering them with older adults who have early to mid-stage dementia, and providing respite for 6 hours a week, 3 hours a day, twice a week, for family members who are caring for them. And so these are some of the numbers that we see with this model, and an important number that's not on this figure is that 73% of family caregivers said that this program alone was all the break that they needed. And so, I think when we look at traditional daycare models or other service models, we really need to look at also what is the maximum value, per hours per week that we can kind of provide to these caregivers. So this was fantastic. It was run through a huge grant that the Eisner Foundation sent over to UCLA, and we worked with them to implement this program. But how can we make this program a reality at other college campuses? And we know that students are interested in this because we had 60 to 70 students apply quarter after quarter to be involved in this program, and we only had about 20 spots or so. So that's when we created Youth Care. Very similar model. Created it at $15 an hour, which we initially are using that money in order to fund a nurse to oversee the program. So there's clinical supervision, rent the venue, get our own insurance, basically make everything clean slate to where colleges should be okay with liability and all the other things that they are concerned about their students getting involved in, and make this something that can scale to other campuses. So we just recently launched this at the University of Southern California, but before I go into that, I wanted to play this video. I don't know how I... Okay, let me see here.
Do you know what is the most expensive disease in America? Surprisingly, it's Alzheimer's, and here's why. Alzheimer's is the 6th leading cause of death and affects 5.3 million Americans. But beyond that, there are 15 million other Americans who provide unpaid care for those with Alzheimer's. This unpaid care leads to an economic loss of $230 billion. And even worse, 40% of these caregivers will go on to develop depression. My name is Nihal Satyadev, and I'm the CEO and co-founder of the Youth Movement Against Alzheimer's, or YMAA for short. YMAA is the nation's leader in providing opportunities for undergraduates and high school students to advocate, research, and provide care for those with Alzheimer's. And now, we are launching a social enterprise, Youth Care. We will pair seniors with Alzheimer's and undergraduate volunteers one-on-one at a dementia-friendly venue for 3-hour sessions twice a week. We will recruit early-stage Alzheimer's seniors to our program using doctor's referrals and marketing via community Alzheimer's organizations. Family caregivers will be charged a low hourly fee, and for them, it's as easy as dropping off the seniors and picking them up. So how can we know that youth care will work? Well, our organization is already operating a similar model, Timeout at UCLA, in partnership with the UCLA Division of Geriatrics. This program has a wait list of over 90 seniors, but we want youth care to be more than a respite care program. We are working with Dr. Gary Small of UCLA Longevity Center to license their Brain Boot Camp, a memory training program backed by 17 years of research. This model is a win-win-win situation for students, seniors, and their caregivers. By giving a break to caregivers, we hope to improve their quality of life and empower them to provide better care for their loved ones. By providing students with hands-on volunteer experience, we hope to inspire them to join the fight against Alzheimer's disease. And for seniors, by providing a friendly face week after week, we will bring light back into their lives. Alzheimer's has left millions of Americans hopeless without affordable care options. With your help and our team's passion, I know that together we can create a future worth remembering.
So this has really been the focus of our organization since we've launched this model, is really how do we get young people to take up volunteer respite care, incentivize them in order to provide massive healthcare savings. And I think the video talked about the wins in terms of the model, the people that are involved in the model. But the other huge win is through reduced stress for family caregivers, the potential for aging in place, and the potential to have that offset burden lead to people not going into assisted living facilities and nursing homes as quickly. And so if you take a model like this, really any model that is focused on volunteer respite and expand that to 1% of Americans who have dementia today and help them age in place for 2 months, that's a cost savings of $1 billion. So volunteer respite and low cost incentivized respite has a tremendous potential as we continue to fund the cure to provide transformational solutions for the care. So we launched this model at USC in February. We're working through building out a more robust referral system, and that's really been our barrier to success, and that's something we're continuing to work through. But in terms of student engagement, for example, we launched it in a new campus. When we launched it, February is mid-semester for USC, so most students already know what they're investing in terms of their activities and whatnot. And we still got 40 signups in 2 weeks with $0 spent on marketing. So people understand that students and young people definitely understand that if this is not something that we are actively engaging in right now, the ramifications are multiple fold worse if not addressed. So we also, in between that time of launching it, we built out a web-based mobile application around this. This is something we're still in the early stages of beta testing. And, through this, we basically get rid of the per-site administrator, which we would need in order to have that person, go and get the seniors information, get the information from the caregiver, get the information from the students, partner them up based on similar career interests and hobbies. And all of that would be done through the app. The payment would be done through the app. So if we ever went on to work with insurance companies or anything like that, this would be a very easy platform for them to plug in any services that they have. And it's also, being developed by IBM grads. So all the security around it is going to be pretty safe too. And then, after we beta test it, we'll of course go through HIPAA regulations, make sure that's all clean. And then this sort of technology, and I mean, there are other services out there too, but allows us to also shift potentially into in-home care, which is not something that we as an organization have done just because of liability work-throughs with with universities, but there is the potential of doing that as well. And that brings us to the legislation we're working on. And I think this is most relevant to most of you in this room is when we saw the success that we were having in the service level in working at the university. And we also saw some national legislation around creating a care corps. It was immediately easy for us to go there, go to DC and start lobbying for this. And when I was there was really not much follow through. It was originally a $350 million ask, then a $10 million ask, which is what I was lobbying for. And there was, people just weren't responding to emails. And so we decided, why wait? Let's bring it to the home state. We have a much more functioning legislature, in my opinion. And let's, create a platform where we can show leadership through our state in order for the federal level to take it from there on out, or for other states to follow California's lead. So it's modeled very similar to AmeriCorps in that high school and college grads would receive stipends for about 1 year, and then upon completion of their year of providing full-time non-medical respite care, they would be given a grant that can go towards their student loans or towards further education, but a higher level of grant, and this is part of the differences between the other core programs, but a higher level of grant if they go into healthcare fields. So a very good opportunity for workforce development, for individuals to enter into labors and really start creating opportunities for us to address the massive hole that is our aging workforce. In addition, some of the other differences are that providing care is not exactly the same as working in a community nonprofit. So there is a write-in for a 6-week short-term dual internship program that dually verifies with the student saying that this is actually what they do want to sign up to do for 1 to 2 years, and also in being partnered with a family caregiver, allowing that family caregiver to qualify whether the student is indeed qualified through personality traits, communication skills, in order to be doing this for that allocated amount of time. And then the final thing is that this is a legislation that will be sunsetted. It's a 5-year period, $5 million each year that is being requested. And during that 5-year period, there would also be a research council, a research committee to really assess the outcomes of this program, both in terms of workforce interest, in terms of caregiver outcomes, and also in terms of purposeful aging, and any other outcomes that people who have a lot more academic skills than I do would deem applicable. So this really, I think, is an opportunity to address some of the things that Kathy brought up, and I think we really are the state to do it. And I think, like Kathy said, in leading efforts in 1984 to create the California Caregiver Resource Centers, 2002 to create paid family leave, this is another opportunity for our state to lead by example, to show that we are a society that is committed to service and a society that is committed to helping those amongst us who are most vulnerable. And I think it also follows in a more national scope, the intentions of corps in the past. When Kennedy first signed the Peace Corps, the idea was to show American exceptionalism across the world through service. And then in AmeriCorps, when Clinton signed that, in order to show that young people are committing to service. And I don't think that there can be anything more patriotic in terms of where our country is headed than providing help to caregivers. And I've seen how difficult that is firsthand through my family. And that's really the motivation for a lot of our team members, knowing that no matter how difficult the work we're doing is or the challenges we face as young people, there's really going to be nothing more challenging than what the families we are trying to help are going through. So it's a little bit of a different paradigm when you're provided this opportunity to experience this as early in life. So this is some of the amazing coalition partners we've built in supporting this legislation. When we tried to push it through this last cycle, we will be reintroducing it this next cycle and hoping to continue building this coalition further. And as soon as California passes this, I have 3 other states that are in contact who are willing to pass this. And we're not really waiting for state by state either. This last 2 weeks ago, I had an opportunity to go to DC, and during that time spoke with some of the leaders who were pushing originally for the National Care Corps. And the main leader on that, she's most likely going to be governor in New Mexico. And so how do we transition that in finding other congressional champions? And we've already been laying the groundwork to do that in order for the federal government to provide matching grants for states who are interested in leading this effort. So we can have California pushing the federal to push other states and really transform the culture around intergenerationalism and service in this country. So I think some key thoughts as a larger kind of scope in doing this work is I really think Alzheimer's and caregiving kind of challenges the democratic values of our country, right? Because democracy in and of itself is really based on people championing issues that are really important to them. But the realities are, if you are doing the stressful job that is caregiving or you have this disease, the majority, in large part, you are not going to be able to be as engaged. And so we need another generation in order to be advocates for those who may not be able to advocate themselves. The other exciting opportunity that I think this disease provides us politically is that there is unity around this disease, no matter how split Washington is on a number of issues of today, which go across headlines. Year after year, these last 4 years, we've seen massive increases in funding for Alzheimer's research. And that's been even with pushes from the White House to cut funding for NIH as a whole. And so I think when we know that this is a disease that affects Democrats and Republicans the same, we can leverage that in order to talk about, okay, well, if we are funding research, across both Democrats and Republicans, why are we not funding social determinants of health? Why are we not funding other issues that are leading to higher rates of this disease, which I know you, Senator, you, Congresswoman, you, State Senator, have had in your family? So there is that opportunity to do that as well. The other thing is leading by example. And what I mean by that is young people are already doing this. We don't need, when we go out and are having these meetings, we don't have to show that this is, but hey, like young people need to be involved in this too. We have several examples of people across our chapters who've done a number of things, and through our partners who've done things like creating technology in order for facial recognition so that people who have dementia can more easily recognize the people around them. And I think there's amazing technology that's being developed in virtual reality to help caregivers to lower the cost of training for how to effectively provide care. So I think, our generation really doesn't get the right rep in terms of millennials. And I think there's a number of exceptional people who I've come across that are actively looking for solutions, whether they're affiliated with our organization or not. They really understand the massive opportunities that gerotechnology and other fields present. And then finally, there are some generational challenges. And I think in our generation, our biggest challenge, which we kind of see across the headlines, is going to be, of course, how do we work through this political landscape? How do we solve issues of climate change? And I think more and more, we just need to really put this issue right up there, because in terms of the numbers, it is 100% up there. And when we solve this issue, we're also looking at directly solving a lot of other issues downstream in healthcare, in our society's culture. And I'm really excited to be working with all of you in doing that. So thank you so much for having me.
Kathy and Nihal, thank you so much. I have two words, and they're rock stars. I mean, these are folks who really know this work inside out. I hope you have been prepping your questions and your thoughts. We'll take a short break, ask you to be back by 2:30 so we can get started right away, and then we'll have an hour for discussion, dialogue, maybe even debate. Thanks. Well, hopefully you've had time for a little refreshment, stretch your legs, and meet some new people, exchange some cards, and there'll still be opportunity at the end of the session to do that as well if you'd like. So we're going to move into our dialogue and Q&A. And as I mentioned earlier, Ms. Sandra Perez is our moderator, so we're very appreciative to have her with us. And I know that you've all been stimulated, I can tell, by the types of conversations and buzz in the room. And so we will get started. Sandra, take it away.
It's green. I'm asking, oh, there he goes. Okay, take some time to warm up. Good afternoon, everybody. I'm so excited to be here. Thank you, Joan, for inviting me. As she gave an introduction, my background, more than 30 years, is in and around the Capitol. I've worked in the executive branch and the legislature, started in the legislature, kind of ended in the legislature, but I've done 2 gigs in higher education. Worked all of my life as an advocate. So it's just fun to put all that experience together, but then to be given the opportunity to ask questions, that's my forte. I really am very curious, but I know you all have a lot of questions, and I know there's so much to offer in the audience. So I just want to ask a couple questions, and then we're just going to open it up. Kathy, just on the policy level, one of the things I was reading recently was that in Maine, a state that has been deemed the oldest state in the nation, I was just looking at what are they doing? Do we learn from other states? And one of the things they said is that they are finding that doing it at the local level is that's where progress is made. And I just wondered, I'm thinking that California is such a large state that how does that apply to California? Do you think locally that's the best way to go? And then later I'd love to hear from people in the audience about what's going on locally. So,
well, I can't speak for all communities in California. I think there are some. It's interesting when you look at who's supporting financially, the family caregiver programs, and it's true that there's actually probably between 200 and 250 communities that have imposed special levies or special set-asides in the budget for senior services across the country. Very few of them really have explicit caregiver support programs. I'll talk about one program, however, in San Francisco called the Dignity Fund. The Dignity Fund was enacted about 2 years ago, really came into being in terms of its funding last fiscal year. And the Dignity Fund was a group of advocates. San Francisco is a pretty tight-knit community. I wouldn't say this is true of all counties, but actually, people wore to the hearings. They had a Dignity dog costume. I mean, a dog costume, literally. and different people wore it. So it was the Dignity Dog came to testify. But it works in San Francisco. It may not work in all communities, but it seems to work there. But the Dignity Fund is interesting because it had 5 components, and one of the components was family caregiving. And this is not insignificant money. It's going to be $30 million in a few years. $30 million, and one of the components is family caregiving. And so, we've applied, we have extra respite money, and we do special outreach into API and more services. It goes to say that, it works in San Francisco because boats have risen a lot, in terms of property tax revenue. Not all counties are the same, but around the Bay Area, it's one of these other things I track. Property tax revenue has risen between 12 and 17% a year for the past 3 years. That's not an insignificant amount of dollars. But the advocate community is not organized in a way to go after money, by and large, for these kinds of funds. What will happen out of this is actually a lot of innovation. And so, yes, it does happen at the local level. It doesn't happen in all places. But the states really should be the living laboratories for these experimentations. And, across the country, there's a few states that are really standout in terms of their support for family caregivers. I mean, California is, to a certain extent, but if you're looking at issues about integration around caregiver assessment, Washington State comes to mind. Minnesota, they're perennially the favorites. They've got bumped off they've lost their crown in the last scorecard that's put out, state scorecard by AARP, Public Policy Institute. So there's quite a few states that have done some highly innovative things, including, so I'll just give one more state example and I'll stop talking. Hawaii in the Kapuna Care program this was at a statewide level, although it's not, it wasn't enacted statewide, so that's kind of a misconception in a way, but Kapuna Care is being pilot tested in a number of different locations for working caregivers to get a daily stipend in order to defray the costs of care so they can remain in the workforce. There was a small stipend program like this that was tested also in San Francisco, just making note. So there are these little laboratories of, doesn't have to be enacted across the state, but it could be a pilot program that's tested in a few areas, and that might be a way to go for some of the things that we're talking about.
Yeah, it's a very complex, and there's no, like you said, silver, what do you call it, bullets, no silver bullets. Well, I have one other burning question, and then I'll open it up to the audience, and that is to Nihal. So I noticed in the picture that there is a majority of guys in your picture. When I look at the room, it's majority women. So I want to know, what are you doing to recruit folks? Because today we're going to talk about engagement and policy change. And so this is, I mean, it might sound minutia, but it's very important. How are we going to engage people? And I think I'd love to hear how you did it.
Yeah, so our engagement strategy is just directly talking to people. So we basically, our advocacy focus was the initial impetus of the organization, and really just to get the message out there that, hey, there's this huge healthcare issue that no one's really talking about across our generation. And so our first year, actually, we reached out and had 30 students start a chapter, and that was kind of like a live and learn kind of thing. A lot of those chapters kind of failed. We didn't give them enough opportunities to grow, and eventually we had fewer chapters, but they're a lot more robust. So I think the way we were able to create something that is now sustaining, we've seen all but one of our chapters continue from last year into this year. And the key there has really just been opportunities to engage people across the college timeline. So freshmen, sophomore, junior, seniors, giving them different levels of leadership, different opportunities to progress, and different skills to learn through the lens of Alzheimer's. So to give you an example of that, our team is made up of mostly all volunteers. We have some pre-meds, so for a lot of them, there's obviously interest in working in issues of health.
but we have someone who is interested in design and media arts. So great, you can design graphics for us and you can be helpful in creating this movement through that. Someone else is really interested in marketing and social media. So okay, be in charge of our Instagram. What are the metrics that we need to do in order to get the most engagement? And so whatever it is that people are already plugged into, just putting this lens of this social issue around it and helping them through this lens develop skills for their career that they need anyways has been a great opportunity for us to engage people.
I noticed you used the word healthcare and you used Alzheimer's. You never used aging or nursing homes, or you never used those words. And maybe, I don't know, maybe that's the clincher. I don't know, but it's congratulations. I think that's amazing, and we need to do more of that. So I know there's a lot of questions, and there's one. Go ahead.
Hello. Hi, my name is Maria Lemos. I'm with Visión y Compromiso, the network of promotoras and community health workers. And for those of you who know our work, we seem to be the logical one to move into this space. And in reality, promotoras are already in this space. Across California, we've developed caregiving curricula and are very interested in partnering with our two speakers, and I've spoken to them. But I think that what's important for me to share is that we are a resource across California, and promotoras have taken an initiative already to develop caregiving curricula, to find ways to partner with organizations, to share their resources, and to build their capacity to provide services to the Spanish-speaking community in particular. I think that would be important, as I noticed the 17% participation in your resource centers. And then, as Sandra mentioned, mostly guys and mostly white, and so we'd love to bring a color to the demographics of yours also. And we're here to help. Thank you. That wasn't a question, it was a statement, sorry.
Well, Maria, I have a question for you. So how do you engage Latinos? How do you engage Latinos to understand what caregiving comprises, how to access training programs?
We're already doing it. As a community, we're already helping each other. That is the core of a promotor. It's that person that goes around and helps and assists. The barrier is not understanding the system, and the system not being relevant to them in their area, if it even exists. So if there is, for instance, a senior facility in a city, not all cities have the bilingual capacity, or the food is not relevant, the activities are not relevant. I'll give you an example where I live in the Bay Area. It's a very small city, but we have a senior center. It's very active, but the activities are not relevant to what I want to do, nor do they provide the activities that I'm interested in. If I was Spanish speaking, they have Chinese and Japanese languages, but they don't have Spanish. And so it is that awareness of what's near you and how can you take from that and adapt it, which is what the comités, we have 14 committees across California, and they take these resources and then they pull from them and they adapt them to what their needs are. That's where the curricula comes in. And then they share it with other family members, or other community members. They're doing workshops on what resources are available. And then they find somebody in that area that can interpret it for them. And then others come to them. So it starts with 5, it goes to 25, it goes to 100, it goes to 200. And before you know it, you've got counties of promotoras with promotoras in them who are fully involved and knowledgeable about these resources. And then we have a lot of training, community trainings for them. So in the piece that you're talking about in terms of policy and bills, I really support a community piece to that. While the resource centers are great, I think that we also have to put resources into community-based organizations and into community groups that are the ones that are implementing it locally. For instance, there's a group in Santa Barbara that's very active, and there's a place called Nukayama, which is out in the boonies. Nukayama is like 10 miles from Kern, but they have a huge resource center. They're part of our system. They inform their community, mostly farm workers, and they built up a resource, a whole library of resources from 0 to 5 to adult and actually hospice. They're involved in hospice now in the home and how to support that. So I think if you just give us the opportunity to do that as a community, we're going to start learning and picking up that information through the network at least.
Thank you for sharing.
Hello. Hello, my name is Alicia Gomes, and I am a AmeriCorps volunteer at the Sacramento Housing and Redevelopment Agency. And I have two questions for Nihal. So the first one, how did you start the organization and get the coordination/collaboration to get the program to where it is today? And what other states have you done outreach to in addition to where YMAA is already established?
So in terms of starting our organization, great questions. In terms of starting our organization, it was literally me and my friends in my apartment. And we just started reaching out to friends of friends and using, the network of fraternities and sororities, using the network of cultural organizations, really just mass emailing whoever we could get our hands on. And so for the first 3 months of our organization, we met every week in my apartment that didn't have AC in the middle of summer. And then basically, because it was too hot sometimes, we'd go to the basement of one of the nearby fraternities. So it's super grassroots, just really people interested in getting engaged. And over time, taking all that interest and working through, okay, now how do we learn the business behind this? How do we learn the operations behind this? How do we take this from just a group of people to more organizational structure? And I think a big aspect of that, though, the few learning lessons, one of the few learning lessons that I've learned in this short period of time has really been who you have in leadership really matters, even if it's in a club level or a young nonprofit level. And so just kind of building on what Sandra asked earlier, the key to our chapter success also is having that one rock star that's really willing to lead this effort at their school. So in terms of states that we're in, we have chapters in Alabama, South Carolina, Illinois, and Florida, a few other states, and a bunch in California, about a third of the UC system. And so beyond that, in terms of the core model, I think there's been interest primarily from Tennessee, Minnesota, and Massachusetts to do this sort of model through their policy efforts. But also I think will likely, if this Congresswoman becomes governor in New Mexico will be likely to take on this program as well.
Okay, awesome. Yeah, I was going to see if Massachusetts was another state that was interested or you have done outreach to, because I'm actually from Massachusetts originally.
Oh, great.
So I figured Massachusetts is also very progressive in their healthcare policies and advocacy. So that's awesome. Thank you.
Let's touch base after.
Hi, I'm Sheila Allen with YOLO Healthy Aging Alliance, YOLO across the way. We were YOLO before YOLO was cool. You only live once thing. So my question is actually for all three of the panelists, including the moderator. I am very interested in advocacy efforts, as is YOLO Healthy Aging Alliance. And I am really happy that there's a lot of talk and a lot of discussion now more about how can we move our advocacy message forward. But I am now getting a little concerned that we have the advocacy collaborations and groups are kind of sprouting up like tulips in the springtime. And I would like for us to try to figure out how we can work together so that we can get our message focused enough so that we can get the attention of not just the elected officials up at the Capitol, but also the community so that we can bring more of the public along with us.
Well, I'll take a stab at it first. I was mentioning to somebody during lunch about the California endowments. Changing the narrative is what I think needs to happen. We need to change the narrative, the image. We need to find what drives our culture. We were talking at lunch about how in our country, the values are not necessarily always about public good. We are driven by entertainment. And I was talking about the Kardashians. Boy, if the Kardashians got old, or needed caregiving, it might change things. But we need to change the culture. We need to change the image. Advocacy is difficult. I mean, it's a combination of many things. I think the media, the image, like I said, entertainment, but data is very important. I just came from working from the UC. And my job was to bring evidence and data to the state capitol to hopefully develop evidence-based policy. But my years working in the legislature, I know better than that. That's a really, really hard thing to do, okay? So you have to think about the politicians that you're trying to influence and what their term limits are, what are their interests at the moment sometimes. And we have something we can talk with Kathy about, maybe she knows on the state level. We have Senator Wesso, who just introduced bills. I know his father is suffering from Alzheimer's. So you can see it's always personal, and it's image, and it's money, and it's their term limits, and how are they going to get reelected, who's in their district. So when you're a lobbyist, and maybe we have some in the room, but you have to think about a lot of things. So advocacy, I think, though, and this is part of our goal today, is really how do we change things? How do we engage things? So advocacy, I'm thinking at the level of the human resources department, right? Can you all go into your human resources department and ask them, what do they do for employees when they lose a loved one or a parent? Or what do you do when you're a caregiver? If we have so many caregivers, we know they're working, they need support. And what's wrong with human resources helping out? And I was sharing with Joan that I just came from the UC, and bless their soul. They're not perfect, though, and HR is not perfect anywhere. It's very, very difficult. But my mother just passed in January, and when I told my human resources person, and as a former manager and director, I knew what they should tell the employees, but she never connected me to an awesome resource called Elder Care that they have at UC Berkeley. And so that was, I was in shock that she wouldn't say anything to me. So anyway, there's lots of ways to advocate. How to make change takes a lot of different things, and changing the narrative for some issue like this, which is so complex, and it's like healthcare reform. I remember being, I was with the Schwarzenegger administration, and of course he came from Austria and said, are you guys crazy? People don't have healthcare. And so that's where we started from. But it's so complex, and look how long it took. And I feel like when we're trying to change a system like this with caregiving and taking care of our elderly, it's going to take an earthquake, a revolution, just like it did with healthcare reform. So anyway, I'm sorry for the long answer, but it's just, I kind of just put all my experience together, and it's a hard thing to change. It's challenging, but I think you can start, and I always change. I ran a fellows program, and so I coach a lot of students, but one of the things I said, you can make a difference, but you know what? You can make a difference one at a time before you can change the world. So start with your HR department and your neighbors and your local elected officials. Anyway, and so what do you want to add, Kathy?
Yeah, I think, working at the local level, what I see happening now is that there's a lot of organizing around age-friendly cities, healthy cities, those kind of more bundled approaches. And, for thinking about it through the caregiver prism, that there needs to be, the issue needs to be raised within the context of those efforts. There's a lot of communities, at least around the Bay Area, that are working on some kind of age-friendly initiative, basically. And so caregivers may or may not be noted, or sometimes they are, but they're kind of like, oh yeah, and then there's caregivers. But you don't really know what to do with them. The offshoot of it is, in some of my earlier iterations of jobs, I did do a lot of program development at local levels, by putting in the volunteer-run respite care programs, within churches and stuff. There's lots of different small things you can do. On the policy writ large, if we're really talking about advocacy for change, it just depends on where the lever is. What do you have to change? Is it is it a policy that's really within your county community in terms of appropriation of resources that might be driven to a certain direction, like my Dignity Fund example? Or is it, something that you think needs to be enacted within a broader healthcare system that might be a regulatory or a state change, or we should have, tax credits for, earn credits for Social Security. If you drop out of the workforce, you should be able to, that's a federal. So it's all the levers are up and down what I would call the political food chain, and you have to figure out what you want to do. But that should not preclude the issues around starting, like a chapter of a youth, a youth movement, Alzheimer's youth movement to within a particular college that's in your community, trying to match, some philanthropic efforts to try to help fund some of the initial, kinds of costs to get it going. There's all sorts of ways that you can do it. There's all sorts of ways that you can get involved. And so, it just depends on what it is that you want to do. Do you want to make a very direct change for people directly in your community that will increase services or at least awareness? Or do you really want to move those levers of policy change? Then you have to know which lever that you're after. And then you have to find your affinity group in order to help move that along.
So I just want to add on to what Kathy said, because I think your question really is in two parts. I think obviously as a community there needs to be priorities, but also I think we need to flip the switch in thinking in terms of an abundance mentality. And what I mean by that is, for example, like this last policy effort, our organization spent 2 trips on flights, and that was our costs for getting this bill through Aging and Long-Term Care Committee unanimously. And what we've been able to do in doing that is bring in stakeholders that you wouldn't even think about. So one of the organizations that supports us is Swipe Out Hunger. What do they have to do with Alzheimer's? Nothing. But it's so easy for them to say, a nonprofit to say, this is a great idea. Let me just put my name behind this. So simple for any organization here to look at the work of promotores, the work we're doing, the work that's being done with dementia care workers, right? Like if we prioritize one organization's work over the other, that's lacking the opportunity for us all to make gains, right? And I think all of us have the ability to write a letter in support of some initiative. And if every single one of our bills are coming through with 100 supporters, how much more effective are we?
So Catherine Sexton, UC Davis, Betty Irene Moore School of Nursing, Family Caregiving Institute. So is there currently a database where advocacy groups could put in what they're working on so that if there are multiple groups working on the same effort, that we could collaborate together in order to have more of an impact?
I would say that there's probably around age-friendly cities and, WHO kind of accreditation, probably people would know more about who's doing what, but there's no central repository for these things unless somebody in the foundation world wants to correct me. I just don't think there is anything that's around. That's why the California collaborative is so unusual, because we have 37 organizations together. Everyone shares what they're working on in terms of policy, bills that are coming up. So it's not an the collaborative takes endorsements, will sign on to a letter, for example. But it's just knowing what everyone is doing is really important. And there's not that many mechanisms out there for sharing this kind of information, so you're right.
However, I look at Nihal because when sharing information, social media, is there something there we could do? I mean, I'm not a pro at it. I don't even use Facebook, so I'm just asking the question. If you wanted to share ideas between groups on campus, I mean, how do they do that?
Yeah, I think idea sharing social media is fantastic. I'm honestly not that good at social media. I don't even run our organization's social media, but I do think in terms of spreading the message, there needs to be cohesive campaigns, and I think there have been, great efforts like Scan Foundation has done the Do You Care campaign recently around millennial caregiving, and that's starting to pick up. The national, just speaking in the millennial space, the Leading Age has done a campaign around millennials too at the national level, and I've seen a lot of posts about that. So I think just, simple things like, matching hashtags, posting at the same time, trying to get these things trending at the same time are really beneficial. But I think in order for quick, massive change, especially in these news cycles, you got to have a major event happen. You got to have some reporters that are willing to conceptualize an undercurrent in our society and make that relevant to the now. And unless we're able to do that event after event, it's going to have to be super grassroots.
I'm Tony Colley-Perry. I represent a nonprofit as a consultant here in Sacramento, Yes to College. But what I was a Vista, so I'm really feeling what you're doing 100%, because it has to be personal. I think sometimes we realize my mother is ill and we're in need of a caregiver plan, and everything you said was personal. And so once it becomes personal, it's easy to leverage unity. It's easy to make it public. And I really like the idea of leading by example because it puts urgency to the messaging. And so I really am going to be thankful. I definitely want to talk to you more about this, but I think sometimes none of us want to think about our parents needing this, so we put it on someone else. But it's really right in every one of our homes. My mother needs, my sister's the leading person in Las Vegas taking care of my mother, and she's tired. And just yesterday she said, could everybody just call? It would be nice if everybody would just call. And I'd never really thought about it, but I'm busy, and there are days that I don't call. And I can see how that 3 hours could make all the difference. And I really wanted to say something because he said his idea and model was successful. And it alleviates a lot of the pressure for the caregiver. And yeah, I could call, but you get busy. And my sisters, they're all doing it all by herself. And I never really thought about it again till today. So I really want to thank you for being here.
So just to follow up on some of the things that you said, one, super cool that you're a Vista. Second, in terms of calling, that's actually such a problem that there's a startup out of UCLA that all they do is literally just have nurses call elders. And it's really successful and it's growing quite rapidly, and it might go into Y Combinator, we'll see. Again, another opportunity of millennials taking the reins on this. But also, I think what you pointed to in terms of like us all having it in our families or making it personalized. And I think, Kathy was mentioning earlier about how, she has 2 daughters, but if we can really change the perception of, it's not just going to have to be like our personal kids caring for us, but our community's kids caring for us as a whole. Because, I think the number is 1 in 7 people who have dementia live alone. Like, I don't even higher, maybe. I don't know the exact statistic, but like, that's ridiculous. Like, how can you even live alone and have dementia? So just moving more into a community solutions effort, I think, and changing the culture around that is going to be a big part of the success.
Hi, I'm Pat Zrellik. I work at Kaiser. I'm a clinical practice consultant there. And first of all, both the speakers were fabulous. And Nihal, I'm really amazed by you. You're wise behind your years. It's really impressive. 2 of the questions that I had is, you talked about a standardized assessment tool to assess for family caregiving at discharge, and also to standardize the hospital discharge process. Where can somebody learn more about what are those data elements and the work that's being done in that area?
On the standardized assessment tool, we did, and this was in 2002 or 4. I kind of lost track now. We did a national consensus conference around what would be the elements of caregiver assessment. We didn't say, here's the holy grail of an assessment tool. we said, what are the elements of that assessment tool? And you can find that piece of work as a toolkit or a report on our site. The point being is that, everyone wants to do an assessment, but the more critical point is, what are you going to do with the information after you've collected it? So if you assess and don't address, please don't even do that, because it just makes people angry to get asked a bunch of questions and have nothing as a result. But if there is something to address, it really depends on where you're going, what's going to be the response, what can you respond to, and then titrate the assessment accordingly. We assess on, a wide range of things. I call it just the 3 buckets, and just makes it easier: planned care, direct care, planned care, and self-care. And the individual measures kind of cascade down under those 3 understandable rubric. But there's many different assessments that are out there. Some are proprietary, some are built in to gather questions for caregivers that are routinely and standardly used within healthcare settings. And others are titrated according to what it is that you can provide. So there's plenty of information around caregiver assessment in the uniform. So that's the first question. The second question was, what was the standardization? The standardization of the discharge process really comes under, to a certain extent, is the purview and the desirability of intent for the CARE Act, which was to be able to assess and address the information and training needs of the caregiver, the patient and the caregiver at the time of discharge, according to what they need to go home for a safe discharge and feel comfortable if they're doing care that's different than what they've experienced before. Right now, there's a sort of evaluation that's going on around what different hospitals are doing. It's hospitals that did a good job of this before there was ever a piece of legislation, or still doing a good job and maybe have improved. Those that are that haven't been, that this was not a routine kind of culture change in practice, are turning the ship around and embracing that kind of practice. It's a relatively new piece of legislation. It's been enacted in 39 states, I think, and at various time periods. So I would say that discharge is relatively idiosyncratic. There's a lot of variations of experience, but the CARE Act is trying to bring that together and make it more uniform. But right now, I'm not aware of any strict standards for the practice and protocols with that.
Hi, my name's Gina DiGiusto. I'm a senior attorney at a Bay Area nonprofit called Housing and Economic Rights Advocates. And I mostly wanted to thank Kathy for highlighting the component about the financial impact. So what I think a lot of the direct legal services organizations, you'll find a lot of them will focus on seniors, but in our organization, one of the reasons we're here, we're kind of newbies to the game, but one of the things that we were noticing is that the clients we were seeing were not only the seniors, but quite often it was the caregivers who were facing foreclosure, debt collection, those types of issues because of the financial strain. And so I think another piece, it would be very interesting to get legal services organizations involved, because we are the ones on the back end that are seeing kind of the impact of the financial strain. And then the other thought would be, or maybe it's more food for thought or a question for you about whether or not you've thought about it, because you talked about training for caregivers and you mentioned how some individuals are asked to do very challenging or kind of high level medical care, but also caregivers are also dealing with financial and legal issues for whoever they're caring for, and often they come to us to ask the questions. And so I'd be curious to see what's the thought around training, not only in terms of the physical care, but also all the other, financial, legal components of the care.
Mm-hmm. Yeah, we do quite a bit of work with families around legal and financial planning. When families come in, I would say roughly somewhere around the mid-30s, They actually have done durable powers of attorney for healthcare and slightly more for financial. But that, you say 35%, that means that there's 60 to 70% that really haven't done anything. And advanced planning is even lower. In certain communities, in certain ethnic communities, that number is lower than that. Just saying, because we track that data. And so there needs to be a different education component. I don't have the answer to that, I'm just saying, but that's what we're starting to notice in the data, and it's really important. We are about to release a fact sheet that I wanted to call Before You Quit Your Day Job, for people who are going to leave the workforce, to really talk about the financial impact. Someone leaving the workforce, it's been estimated to be over $300,000 of lost wages and opportunities and benefits. And so, trying to find that kind of balance, it's a fairly lengthy fact sheet, but that's one of the things we try to do because, almost 60% are in the workforce. Sooner or later they go, well, if I pay for this, it really doesn't pay my salary, but they don't understand there's other benefits as well, like Social Security and other benefits, health insurance and other things. Besides the fact that a lot of family caregivers, their sanity is in their job. Mm-hmm. Their sanity is in their job. And there's a lot of families some families, it's great, that's their choice. And it's really sad to say, why should this be a choice? Why should I be impoverished by taking care of somebody in my family? It's an honor or duty or reciprocity or, love, all the positive reasons. Why should this be a choice? But it is, it's an economic issue. We do counsel around those issues, and there's an awful lot of family caregivers that say, wow, I really do wish that I hadn't have done that because now I'm really isolated. So we do that counseling. The problem that I see is that there are some times that we don't get people in time. We don't get them in time to at least, if you're going to make the choice one way or the other, we're agnostic to the choice. But what we want to do is make sure that everyone understands the alternatives and the consequences of making each of these choices. That's it. We just want to give them the information to do that. But you're really quite right. It's a big financial hit for most families.
And just a nuanced stat on that topic that came out of USC's Millennial Caregiving Report. So in California, there's an expected 154,000 millennials that are dropping out of the workforce to provide care. And so the reentry for care for employers now saying, why would you drop out of the workforce? It's not really a really clear reentry into the workforce for those families or for those individuals as well.
Yeah. Can I just I'm just going to piggyback on that. It's interesting because we have gotten people in their 20s who have dropped out. Now, I live in San Francisco. This is a conversation I heard on a bus. There was a group of young Asian men, and they were talking about school. They're talking about community college. And he said, yeah, I had to drop out because it was my turn to drop out for a semester to take care of my grandmother. That's a common overheard bus conversation in my neck of the woods. And so actually we did do an outreach to the counseling center at the community college to see, well, how is it that we can maybe perhaps work, better? It's not the most intuitive place that you might want to do outreach, but, just putting this together was sort of interesting. But the other point is that we have had, folks that have dropped out for a year or 2 years, and they've been counseled. So I've heard all sorts of stories. So this is all anecdotal, but it goes along. If one person says it, we know that there's others that have this problem. They don't know how to cover the gap, the work gap, and some counselors, job counselors, helping with resumes say, I don't think I would say that. I don't think I would put caregiving in there, which is kind of surprising because you think, wow, that says something about that individual. But they're saying, no, I don't think you can really cover that time quite that well. So there's like a consciousness that we need to have. We talk big about family values, but here's somebody exercising their family values, and they're not recognized for it.
So just to double piggyback off of what Kathy said, in terms of it affecting education. So this is something that was really interesting to our organization because we'd heard of a high school teacher in New York in a low-income district who got permission from her principal to spend part of every morning for a couple of weeks just having a conversation about dementia. And so what was surprising for her was that close to 2/3 or 3/4 of her students had a personal connection to it in terms of it being in their family or close extended family, but also a significant portion of them were providing the care itself in high school while going to school. And so that kind of spurred us to do two things, one which is inaction and one was kind of a quick stopgap action, which is we're doing a survey now with a couple schools in LAUSD to assess what is the effect of caregiving for high schoolers through surveys that we're distributing out and seeing whether this is leading to poorer rates of academic success, because if that's the case, especially in high school, there's boatloads of information that talk about that education period, primary education period, being directly related to economic success for those family members. And so, and on an anecdotal level, a student who I used to tutor, she goes to a high school in LAUSD where if you have one unexcused absence, you automatically lose 3% of your grade in that class. And so think about how many unexcused absences you might have if you're providing family care. So, are you going from an A to a C just because you're caring for mom? Is it like, do you feel comfortable in your high school talking about this? Are school counselors equipped with the knowledge to talk about this? And so those kind of translations through this survey also translated to the second thing, which is so there was another high school student inspired by our work who started his own organization, and his efforts and bringing in a few other high school students was to lobby his school district to integrate dementia curricula, like dementia-friendly curricula, dementia friends, into their health education. And so basically he got it to the point where he now just had to lobby the district curriculum manager, or I don't know her exact role, and then flew me out for that meeting, and they were convinced. So now for the first time, this school district in Rochester is providing dementia education as a required part of their curricula. And so if we can, and so simple, it's one day, it's like 45 minutes, very basic, but like opens your perspective and just opens the ability to have these conversations that maybe a lot of high school students aren't even allowed to talk about in their schools.
Do you have any contact with the young carers groups around the world internationally? We don't have that here.
One in UK, yeah.
I'm sorry, we're talking offline. There are in other countries, in the UK, as some other parts of Europe, Australia and so on, have young carers associations that have really looked at this and have offered support and education and stuff through those. So we don't really have that, an equivalent movement here in the US. Or recognition, for that matter.
Yeah.
Do you guys have?
Well, I think this is on. I have a lot of questions, and I can continue after we're done. But I think something you've touched on is so important. We've talked about hospital discharge. You're talking about schools. We're talking about trying to teach people what dementia is, and the other part is how to communicate with dementia. And I say that in the context that it's not a very enjoyable experience, probably for students or grandchildren, whoever it is, children, to speak to somebody who either repeats the questions or, accuses you of something and all that. I just think it's so important, and it would be so helpful to have training. I guess I know it's linked to your assessment, but to have the training on how to communicate. And I think, how do we hit all these professions all over the world? In the old days, we used to have PSAs. Remember, you used to have a soundbite, a 15-second PSA on TV, and it would teach the world something. And I just wondered, I wish I could, if I had a magic wand, it would be that, is to teach, like I said, my mom just passed. I'm one of 8 siblings. We have, 19 grandchildren. I have 150 first cousins. Lots of people around, but people don't know how to speak with a person. Pause. It's simply a pause when you ask a question. Or if, and I will shout out to Delora. Delora has helped my family. And one of the things she said was, your job is just to make your dad feel safe, secure, and validated. And so when he says, that's brown, and I say, I don't think so, I say, oh yeah, that is a nice shade of brown. That ability to talk with somebody who has dementia really enhances the experience and maybe encourages people to understand it and engage with them maybe. I don't know. That's my magic wand wish. But I think we're wrapping up. Any last burning questions? Well, we've talked about all the way from personal to policy, very complex, challenging issues. I want to say our goal was to get everybody engaged and think about one thing that you can do as you leave this room that you can do. And there's so much that I know you can pick one thing, but I will say we have election coming up. Everybody vote? Thanks. Anything else? I don't think so. Thank you very much.